Hello, and welcome to Better Man Clinics, the podcast where we talk to actual experts to address the questions that men want answered, but are either too embarrassed to ask or simply don't know who to ask. Before we get started, I do want to caution that the conversations on this podcast are for informational purposes only. They don't represent a medical consultation, nor do they present medical advice to individuals. Rather, we hope that the podcast empowers men with the knowledge and confidence to address these issues with their healthcare providers. As with any medical or wellness issues, you should always consult with your healthcare provider before beginning any type of treatment or preventative intervention. With that being said, in this episode, we discuss Peyronie's disease, a condition faced by about 10% of men. Peyronie's disease can cause pain, erectile dysfunction, and for some men, a complete inability to have sex. But what exactly is Peyronie's disease and what causes the condition? How do you know if you have it? Does Peyronie's disease always require treatment? What are the treatment options and how well do they work? To answer these questions and many more, we turn to a true expert. Dr. Darshan Patel is an assistant professor of urology at the University of California, San Diego School of Medicine. He completed his medical training at the Drexel University College of Medicine in Philadelphia, and then completed a residency in urologic surgery, a clinical research fellowship in reconstructive urology, and a fellowship in men's health, andrology, and microsurgery at the University of Utah. Dr. Patel has authored over 100 publications and textbook chapters. His research has appeared in journals such as Fertility and Sterility, the Journal of Assisted Reproduction and Genetics, Urology, Journal of Urology, the World Journal of Urology, and the British Journal of Urology. And now, without further ado, I bring you our conversation with Dr. Darshan Patel about Peyronie's disease.
Hello, and welcome to Better Man Clinics. Today, we're going to be talking about Peyronie's disease, a problem that affects approximately 10% of men and can cause some serious problems, including bending of the penis, pain, erectile dysfunction, and for some men, an actual inability to functionally have sexual intercourse. A real serious problem. And who better to help us address this problem than an expert on men's sexual health and Peyronie's disease, Dr. Darshan Patel. Dr. Patel, welcome to the program.
Thank you very much for having me. Excited to be here.
It's our pleasure. I think this is a topic that a lot of guys have interest in and concern about. So we're very happy that you'll be sharing your expertise. Before we jump into the issue at hand, I always like to do a little introduction so that the guys know who they're listening to and who's providing their advice. And one thing I always like to ask that a lot of guys email me about is, what actually inspired you to go into urology and specifically to focus on men's sexual health and Peyronie's disease as well?
Yeah, so I mean, the main driver for me in terms of going into urology and then kind of specializing in men's health really has been the ability to positively impact people's lives and really improve their quality of life. And it's nice really to be able to kind of connect with men about sensitive issues that they don't necessarily, would feel comfortable talking to a lot of people about, and kind of reaching, therapies and kind of addressing issues that really are bothersome and coming to kind of good options.
No, that makes a lot of sense. It's definitely some sensitive issues. And, as you know, that's one of the reasons for this podcast as well, because it's issues that a lot of guys feel very uncomfortable talking about and sharing. And in that respect, we talked about, I mentioned Peyronie's disease can cause penile curvature, and we'll go into that a little bit later. But one thing that I know I hear a lot about from my patients is penile curvature in general. Is a certain amount of penile curvature normal in guys?
Yeah, so I mean, that's a great question. And for a lot of guys, they usually turn to the internet to kind of find some additional information, especially if they are worried about developing a curve or to kind of define what's normal and what's abnormal. I would say that the definition of normal, it really depends on who you talk to. I mean, generally, some curvature is considered normal, and we kind of, define that from the literature anywhere from, 5 to 30 degrees. But now we really know that, any man that has significant concern regarding the curvature, or is having symptoms where they're having any sort of pain, discomfort, or their curvatures are impacting their ability to have sexual intercourse, that's certainly a reason, to kind of be evaluated.
So it's really when it starts getting in your way and causing problems. Otherwise, the idea is that curvature is fine. It's not. Is curvature anything something to worry about, like a cause of concern of something serious potentially?
Generally not. Most guys that we see, obviously they, may feel a lesion, and that may prompt them to kind of be evaluated, and kind of the curvature or another kind of penile deformity is really secondary to why they're coming in. And for them, it's really just reassurance that, they don't have, penile cancer or something like that. Generally, penile cancer is so rare, especially in comparison to Peyronie's disease, and usually isn't associated with the typical curvature or deformity that is more pronounced with an erection. So generally, a lot of those guys just need some reassurance. And for the most part, they're happy because their curvature really hasn't bothered them up until that point, and really just want that extra reassurance.
Got it. No, that's good to know for sure. Now we're going to talk about Peyronies, but are there any other conditions to keep in mind that might cause curvature of the penis in men?
Yeah, so in terms of Peyronie's disease, we really consider that as acquired curvature, or curvature that essentially developed when you were adult. We have some patients that we see that present with congenital curvature, or may have had a surgical procedure before, or a condition that may be associated with penile curvature, like hypospadias, which is kind of a mallocation of the urethral opening, or where the urine comes out. Or if they've had epispadias, where the urine opening is kind of on the top side of the penis, and if they've had surgeries related to that. We do see congenital curvature where guys, after puberty, they noted that they had a little bit of a bend, and that becomes more pronounced, and they kind of be evaluated for that. So there are other reasons that can lead to curvature, but generally, any sort of acquired curvature later on in life, or other penile deformity like an indent, or an hourglass shape, certainly we would kind of define as Peyronie's disease.
So that's a good segue. And I mean, when anybody talks about Peyronies, they talk about the curvature or the bend, etc. But what exactly is Peyronie's disease?
Yeah, Peyronie's disease really is kind of a clinical diagnosis. So number one is some sort of penile deformity, and generally we kind of associate that with curvature because that's typically the main thing that can affect your ability to have sexual intercourse. But there are kind of other things that kind of are, play into the definition of Peyronie's disease and acquired curvature. That includes things like an indentation when you have an erection, or kind of what they describe as an hourglass deformity, where there's kind of a circumferential narrowing in an area. Or lastly, you can also have kind of like a hinge effect, where with a full erection, there's an area on the penis that tends to buckle with certain positions. And that certainly can be a cause of concern for a lot of guys if they're worried about having an injury during sexual activity. So there's certainly kind of a lot of things that play into Peyronie's disease, although a lot of the focus really is on curvature.
And do we know what is actually causing that curvature in Peyronies? Like what makes the penis bend that way?
Yeah, so most men have a plaque that develops in the tunica, which is kind of the tissue that surrounds the erectile body. And this plaque or tissue basically prevents the symmetric expansion of the erectile body when someone has an erection. And generally, we don't really know the cause of what leads to this plaque, and subsequently leads to Peyronie's disease. There's kind of a lot of research in this area, but the thought is that there's kind of this abnormal healing process that occurs, and ultimately there's kind of deposition of collagen and basically just scar tissue that occurs at this location where the plaque is. We do know that There are certain things that are associated with Peyronie's disease as well. The idea of developing penile microtrauma with sexual activity, where there's kind of a repetitive injury to kind of the same area, and over time that can lead to scarring. I would say that we usually ask about that in terms of guys that are coming to see us, in terms of do you remember a time when you had kind of an injury with sexual activity or penetrative intercourse? But it's not that common. I would say maybe 20-30% of guys remember an incident. Generally, the cause is unknown, and it kind of just comes out of the blue. Certain autoimmune conditions certainly can be associated with Peyronie's disease, such as lupus. And then lastly, there are other superficial fibrotic diseases that correlate well with Peyronie's disease. One is Duprints Contracture, which basically is scar tissue that can develop in the palm of the hand. And that's actually, fairly, comorbid. So in folks that have Dupuytren's, so the scar tissue in the palm of the hand, about 40% of those guys will have Peyronie's disease. And then in guys that have Peyronies disease, about 20% will have Dupuytren's. So there is quite a bit of overlap with those two conditions.
Is there some kind of genetic component there? Like, does it run in families?
It does. So, we're kind of in the early phases of kind of understanding, how potentially Peyronies could be genetic or kind of passed down. But there has been some kind of early research that's looked at specific HLA antigens, and the fact that, a lot of people, if you ask, will have a positive family history for superficial fibrotic disorders. I think the tough thing, at least with just asking about family history, is that not a lot of guys will ask their dad or their brother about penile curvature, and that kind of limits our understanding. But generally, if you ask about the other conditions like Dupuytren's, most guys will be like, "Oh yeah, my dad had that." So that certainly leads us to believe that there is kind of an overlap in terms of the genetic kind of underpinnings of these kind of several diseases.
Got it. Now, the one lifestyle potential issue or contributor that you mentioned was sexual activity, was rigorous sexual activity, or vigorous, I should say, or traumatic. There's a lot of stuff on the internet in terms of positions or whatnot. Is there anything from a sexual perspective that guys can do? I mean, obviously they can't affect their genetics or prevent having Dupuytren's or whatnot, but from a sexual perspective, is there anything they can do to prevent potential Peyronies, like in terms of avoiding certain sexual positions, or is it pretty much just bad luck if that happens?
Yeah, I would say there really isn't a lot of good evidence to suggest that specific sexual positions or other kind of lifestyle considerations, could prevent or kind of change the progression of Peyronie's disease. So a lot of guys will ask about, there's something that I can change in my diet, other, over-the-counter supplements, weight loss or things like that. But generally, you're really not going to really change the course of Peyronie's disease. Once you kind of have it, generally about 50% of guys will have progression of their disease. So if they have kind of some curvature, it potentially could get worse. 40%, it probably stays about the same. And then 10%, it could get a little bit better, but it really depends on kind of where you're starting out at, and where you're being evaluated at in terms of the amount of curvature that you're presenting with.
Now, speaking of that, so starting off let's begin at the beginning. So there's guys out there saying, maybe I have Peyronies. Mm-hmm. We talked about curvature, obviously, but are there any other symptoms? Like, how does a guy know they have Peyronies, or do they need to go to the doctor to know they have Peyronies?
Yeah, I mean, generally, most guys would be able to kind of understand or have the suspicion that they potentially have Peyronie's disease. The early symptoms that guys may notice is kind of pain with erections. They may start to notice some degree of curvature that is new. And other things that are associated are kind of the things that we kind of mentioned before, in terms of an indent, in terms of an hourglass shape. Some people will report that over time that they've had, shortening of the length of the penis. And it also kind of correlates with, erectile dysfunction, because like we mentioned before, outside of just, rigorous sexual activity in guys that have, erectile dysfunction. The idea of engaging in penetrative intercourse with, a partial erection, that certainly can induce a lot of micro trauma that could, certainly put you at risk of Peyronie's disease. So very commonly we see guys that have both, but we also see tons of guys that are younger, have no issues with ED, and out of the blue have developed Peyronie's disease.
And the question that comes around a lot over the internet as well is, you mentioned progression, the curvature getting worse. I mean, how bad can it get? What's the worst you've seen?
I would say that in terms of curvature, it can get pretty bad. I mean, the worst kind of cases that you'll see is when someone has like 120, 130 degrees of curvature, where the penis basically is kind of, almost bending back on itself. And as you can imagine, that's pretty difficult to have penetrative sexual intercourse with that degree of curvature. But generally in a lot of guys that we see, they kind of fall between, 30 to 60 degrees in terms of curvature. And then there's outliers, obviously the guys that have more severe curvature. And then some guys that, may have did some independent research, may have seen some direct to consumer advertising, and then are coming in just because they have kind of a mild bend and just want to make sure that there's nothing really wrong. And in a lot of those cases, if the curvature is mild and they're not really bothered, we kind of just observe it.
Now, when a guy is maybe listening says, this sounds kind of like me, and maybe they're in some point of progression somewhere along the spectrum. One question, you had mentioned supplements. A lot of guys like to take supplements, and one that comes up a lot for Peyronies is vitamin E. What are your thoughts on that? Is that worth trying? Is that going to provide any real benefit at all?
Yeah, so I mean, the key concern with vitamin E and other kind of antioxidant supplements that are readily available over the counter is that there really isn't a lot of good evidence that suggests that it works. Early on, certainly there was interest primarily in what we kind of define as the acute phase, or when someone first develops pain and starts to develop curvature, where for the most part we avoid any sort of invasive therapy like injections or proceeding with surgery or things like that. But I think at this point, now that we have kind of some good therapies available, we generally do not recommend guys use vitamin E. It's not necessarily going to be detrimental to health or the progression of Peyronies, like making it worse. The biggest thing is it probably isn't going to work.
Mm-hmm. Yeah, don't waste your time basically with it. Now, the other question is, in terms of guys who think they may have it, you mentioned the progression, right? So I guess the question that guys might have is, when is the right time to see a doctor? Do you see a doctor as soon as you notice there's a problem, or you have pain, or maybe it's the erections kind of making it difficult for you to penetrate during sex? Or do you wait it out and see if the progression happens? When's the right time to intervene?
Yeah, so I mean, I would say there really is no right time. I mean, generally, we would say being evaluated earlier is probably better, primarily in terms of getting the right information to the patient so they kind of understand, what Peyronie's disease is, what kind of therapies are available, what's the real indications for us to kind of move forward with specific therapies. Because, like we've kind of mentioned already, a lot of guys really turn to the internet to kind of look up various things, and for the most part may not be getting the most reliable information. Generally, we've kind of thought in the early phases of Peyronie's disease, if there's still significant pain with erections, that generally we would try oral therapies, other conservative measures like anti-inflammatory medications, shockwave therapy, but we would wait to kind of do any sort of injection therapy. But I think really nowadays there is some evidence that suggests that even during kind of the acute phase, or kind of episodes where you're still having a little bit of discomfort, or it's kind of pretty early on in the process from when you first noticed, those guys can certainly benefit from starting injection therapy a little bit earlier.
Got it. Now, one of my goals for this podcast is for guys to really get a better understanding of what they're up against when they go see the doctor. As we talked about at the beginning of this program, it's a sensitive issue. Obviously, a lot of guys are embarrassed to go see the doctor and to address this issue. If a guy was to come to see you, they think they may have Peyronies or they know and they want to get treatment, what would they expect in that first visit in terms of questions, exams, tests done? What should their expectations be?
Yeah, I think that's a great question. I mean, generally, we want to kind of be as welcoming and create a very comfortable environment for the patient because they are taking kind of the first big step in terms of coming out and seeking the right care. During that first visit, generally, what we do is take a really good history. We'll do a good physical examination, and generally, that's pretty much it. Unless there are other issues that may factor into the Peyronies disease, like there's erectile dysfunction that's also kind of playing into it, or other medical conditions that we're worried about. We generally don't do any additional lab work or specific imaging. One of the things that can be helpful in folks that we're not certainly positive how much curvature that they have is having them come back with self pictures of an erection and kind of a couple of different views to kind of give us a better idea. Or we offer to do artificial erection in our office with the injection of kind of a medication to induce an erection in the office. Sometimes we also end up doing a penile color Doppler duplex ultrasound, but usually we wait to do that at a subsequent visit if we think that it's necessarily needed. And in those situations, usually it's guys that are considering surgery rather than kind of the less invasive options. A lot of guys will ask, do I need to get a CT scan or an MRI or an X-ray or something else to kind of better evaluate the scar tissue? But generally, those sorts of imaging studies are not recommended because they really don't change anything in terms of management. So if we need to do any sort of imaging, generally it's going to be that ultrasound that we do when the penis is completely down and then after injecting a medication.
Mm-hmm. What does the ultrasound tell you? What does that help you with?
Yeah, so I mean, the main reason that we would do an ultrasound would be to kind of evaluate the plaque. So in some folks that have significant calcification in the plaque, certain treatments don't work as well. And generally probably going to do better with specific surgical options. It can give us an idea in terms of kind of the size of the plaque, but that's not necessarily too helpful, at least if we are considering doing injection therapy. But the more important thing in guys that do have some erectile dysfunction, whether it be fairly mild or pretty severe, it gives us an idea objectively of how bad the ED is, because a lot of the surgical therapies that you may consider for Peyronie's disease certainly can impact erectile function. So, it really is about patient selection and trying to offer the patients really kind of the full spectrum of available treatments. And the ultrasound really will help kind of define, what patients are going to do better with certain therapies.
Well, it's a perfect segue. So, let's say, a guy comes to you, you evaluated him, you've established, okay, he's got Peyronies, he wants to get treatment. Let's go through some of the options. Let's start with the least invasive first. You had mentioned potentially some oral therapies. Can you go into that a little bit in terms of any oral medications that might help in this situation?
Yeah, so I mean, generally we don't prescribe any oral medications for Peyronie's disease. The only oral medications that we would consider would be like a non-steroidal anti-inflammatory medication for guys that are having still pain with erections, so they're kind of early on the process. That certainly has been proven to be beneficial and something that we recommend routinely in guys that are coming pretty early on in the process. The only other real pill that has potentially some evidence would be Potaba. It had some evidence that it can decrease the plaque size for Duprints Contracture, but hasn't been proven in Peyronie's disease. But since there is a little bit of overlap with the two disease conditions, we have some guys that would inquire about just oral therapies and something that we potentially would consider. But generally, there isn't a lot of good evidence for pills for Peyronie's disease.
Got it. So what is your least invasive go-to for Peyronies?
Yeah, so I mean, generally for our patients, we want to kind of offer them the whole spectrum. So usually I kind of tell them that, there isn't any good evidence for pills, and generally we don't recommend it. The next kind of step up would be, penile traction therapy, where there is some evidence for, but it really depends, once again, on the patient's expectations and the amount of curvature or other penile deformity that they have. If they have fairly mild curvature, or they're considering combining the traction therapy with another option, certainly it can help if it's used properly and used for the recommended periods of time. The challenge with penile traction therapy, and a lot of the listeners may not necessarily be familiar with it, but basically the idea is that we want to kind of stretch the penis out to kind of prevent the area that has the plaque from kind of continuing to redevelop more plaque and remodel, so that when you do have an erection, it continues, worsening asymmetric expansion. There's a couple of different kind of models that are available. They're all pretty much available through medical supply stores online. So it's something that you can get without a prescription. There's most of them you have to wear for a certain period of time, at least about an hour and up to 6 hours a day. And you have to kind of, use that therapy for 3 to 6 months. And generally I tell patients that, if you did all those things, the likelihood in terms of improvement in curvature you're looking at with this therapy alone is probably in the order of 5 to 10 degrees. And I would say, less than 5 degrees is, by chance. So there's a little bit of, efficacy that you may get from traction therapy, but certainly a lot of buy-in from the patient's end in terms of doing the exercises and applying the therapy.
Is there any risk to traction therapy?
I would say generally not, if it's used properly and used for the right period of time. If some guys that ask about, hey, what if I just leave it on and then just go to sleep? That's probably not a good idea, because generally want to leave it on for kind of a set duration. Outside of that, I would say that if used properly and it doesn't cause insane amount of discomfort, it's probably low likelihood that you're going to cause some sort of injury or some other side effect.
So it sounds like traction therapy is kind of on the margin benefit, but you can't expect any significant, noticeable, major change or improvement with it alone anyway, right?
Exactly.
So what's next up the ladder?
Yeah, so in terms of kind of next options, or kind of the next or more invasive options, we talk about injection therapies. Thankfully, we now have an FDA approved medication that's for Peyronie's disease, and that's probably the most common therapy that we use nowadays for Peyronie's disease. It's a collagenase, so basically it helps soften the plaque, and when used in combination with kind of mechanical stretching exercises, has been proven in randomized studies to improve penile curvature.
So how we'll get into the mechanism in a minute, but how much improvement, like you said, for instance, traction might be 5 or 10 degrees, which I mean, is like literally barely noticeable. How much honest, truthful, not truthful, how much realistic improvement could you expect from this collagenase therapy?
Yeah, so I would say that with this therapy specifically, the good thing is that we have some pretty good data that supports the efficacy. And now that it's been out for a while, we have, real world data as well. Generally, when I counsel patients, I say that about 40% of guys will get a response with the medication. So that's not everybody. There's some patients that won't get any response at all, and there'll be some patients that potentially we could make things worse. In that 40% of guys that get some sort of response, the average change in curvature is about 20 degrees, give or take. Some guys may get a little bit better, some guys may get a little bit less, but generally 20 degrees of improvement is kind of the benchmark, or kind of the thing that we talk to patients about.
So I guess then this medication, again, just to be clear, this is the Xiaflex that you hear all the commercials about. Is that correct?
That is correct.
So with the Xiaflex, just so guys know, they're looking up the right thing online when they do it. So for the Xiaflex, it's probably not for those with, when you were talking about the 130-degree curvature on itself, that's not going to really make an impact, right? It's probably for the milder curvatures. Would that be considered correct?
Yeah, so I mean, in terms of kind of the indications for the therapy, generally we would use it for guys that have 30 to 60 degrees of curvature, and kind of understand that generally, or even after we kind of complete the whole course, that we may get you 20 degrees of improvement, maybe a little bit more, maybe a little bit less. Are you really going to be happy with that afterwards, or are you really trying to get as straight as you possibly can? Those guys are probably going to do better with surgical options. But if the patient really wants to kind of optimize kind of the least invasive option, certainly we would, consider Xiaflex in that scenario. In guys that have more pronounced curvature, so more than 60, more than 90, the main reason that we may do the Xiaflex would be if they are truly concerned regarding certain surgical procedures and side effects of those. So we may use it as a bridge, because if they start with 120 degrees of curvature and we do Xiaflex and we get them to 80, or we get them to 90, or maybe a little bit better, they may still need a surgical procedure to get significant improvement. But with certain procedures, penile shortening is certainly an issue. And this may circumvent or reduce that impact by kind of bridging them and making this therapy available to them. Otherwise, those guys with the more pronounced curvature probably going to be better served with a procedure where we actually try to cut out the plaque.
Got it. Now you said the Xiaflex collagenase, it breaks up the collagen and the plaque, but how is it applied? Is it as a shot? Is it a cream? Like what are the logistics of this treatment?
Yeah, so it's an injection that goes directly into the plaque, and it's a series of injections of 8 that gets administered over about almost 6 months of time, and there's kind of a specific protocol that we use. With each injection, it's done in the office. So you drive yourself to the appointment. Basically, we prepare the medication. Usually we'll inject a little bit of numbing medicine directly to the penile shaft skin where the needle is going to go in for the Xiaflex medication. And then after that, we pass the needle directly into the scar tissue or the area that it's most curved and inject that Xiaflex medication. And then you're done, and you can kind of leave. So generally the process for getting one of those injections is fairly quick. It doesn't have a tremendous impact in terms of kind of day-to-day schedule, but it is 8 injections. So depending on how close your urologist is, certainly we have some patients that come from further away, that can be a lot of travel time.
Mm-hmm. You had also mentioned when we first started talking about Xiaflex about modeling. What do you have to? What does that mean, and how does that work?
Yeah, so I mean, the original studies that were done with Xiaflex, they included manual modeling, and generally we teach patients how to do that at home. We don't do that, or at least I don't do that in the office or having patients come in for a specific appointment for that. The idea is that we basically want to apply some sort of mechanical stress to the area that has the plaque after we've kind of softened it with the injection medication. And there's kind of 2 exercises that we do. One, basically that would be done when the penis is completely flaccid, where we have the patient stretch out the penis as much as they can and then gently massage the area that has the plaque or where it's most curved. And then the second exercise, when someone has kind of partial erection or kind of if they have morning wood, basically try to bend the penis in the direction opposite of where it's most curved and use that point opposite as kind of like a fulcrum essentially. But most guys, they probably don't do that exercise as aggressively as we would in the office, I would say, if we did kind of in-office modeling. But certainly there is a component to the therapy and component to the, achieving kind of the best results by adding kind of some mechanical therapy.
Does this mechanical modeling increase the risk of the procedure at all, and particularly when you're bending the semi-erect penis, or is not much risk associated with this?
Yeah, I would say there's not much, additional risk associated with it versus just doing the injection alone. So generally, it's pretty safe. The one thing that we say is that make sure that it's still not uncomfortable after the injection before you start doing some of these stretches. So usually we allow the patients 2 or 3 days before they start doing those stretches.
Mm-hmm. So no, it sounds like a pretty benign, not major risky procedure. Again, some moderate efficacy, so not a bad option, I guess. Yeah.
Yeah, I mean, I would say that most guys do opt for the medication. There are some risks, and the most common thing that guys are surprised about is the degree of swelling and bruising that you may get after one of these injections. And I usually tell patients that 30 to 40% of guys will get some degree of bruising and swelling, and each injection is essentially an independent event. But there is a chance that you get very pronounced bruising and swelling called a hematoma. It happens probably about 5% of the time with one of these injections. It takes a little bit longer for kind of your body to, take care of that bruise. But generally it's not dangerous. The most kind of feared complication would be a penile fracture, where basically the plaque essentially ruptures, and then a lot of blood kind of escapes out from the erectile body. And sometimes that can be very painful. A lot of bruising and swelling would be something that would require medical attention. So that would be kind of the most feared complication, and that happens on the order of 1 in 500, 1 in 1,000. So pretty rare.
Got it. Some other injectable medications that make the rounds online are Verapamil and Interferon. Are those still used now that Xiaflex around? And if so, how do they compare to Xiaflex?
Yeah, so I still use both. There's been some access issues with interferon, but up until recently, there are certain indications where verapamil or interferon, may be better than collagenase. Verapamil is commonly thought of as kind of a blood pressure medication, but basically this is another injection that we would deliver directly to either the plaque, or in folks that have a penile indentation. Those guys tend to do well with verapamil as well. The other thing with both verapamil and interferon is that generally doesn't have as much discomfort in the kind of first 24, 48 hours after the injection compared to Xiaflex. So earlier on in the disease process, so guys that are coming in fairly early, still having some pain with erections, but slowly improving, we may consider something like verapamil. We don't know how it quite works. Generally the thought is that it affects fibroblasts, or the cells that put down the collagen or the scar tissue, and kind of changes that process. Interferon, same thing. I mean, another injection therapy. It can be used in guys that have a ventral curvature pointed, down towards the floor rather than up towards the ceiling. Xiaflex certainly should not be used for that, with fear that potentially you could hit the urethra or the urinary channel. So both of those kind of other injection therapies certainly still utilized in the right patient. And cost wise, one of the things we didn't touch on is that coverage for Xiaflex is kind of spotty, although it is FDA approved, and in some men that we kind of go through the process and Xiaflex does not get approved, but they're not quite ready for other more invasive options. We may consider something like verapamil or interferon, which even out of pocket is fairly cheap.
And in terms of efficacy, robustness of the response, about the same, or is Xiaflex superior? What are your thoughts?
Yeah, so I mean, I would say that based on the literature, there have been some studies that suggested that both verapamil and interferon can have as good efficacy as Xiaflex, but those studies, weren't as rigorous as kind of what led to the approval of Xiaflex. I would say generally, I would say that the efficacy of verapamil and interferon is probably a little bit less than the collagenase. It really depends on the location of the plaque, and kind of what the exact deformity is. like I mentioned before, in guys that really don't have a lot of curvature but may have a penile indentation that they're really bothered by, they tend to do better, in my opinion, with the Verapamil when compared to things like Xiaflex or Interferon.
Those are good, some good nuanced advice there, both in terms of the ventral curvature and the indentation. Really, it's more nuanced than just hit this nail with a hammer and go from there for sure, which is good for guys to know.
Yeah, exactly.
But the logistics of the injections, I'm assuming, are similar. There's not much difference in terms of how you describe Xiaflex injections. Same idea.
A little bit different, but typically the numbing process and kind of the injection deployment is fairly similar. The main differences with collagenase versus the other injectable medications is that typically the volume of the medication is quite a bit more. Xiaflex is very powerful. It's a very small amount that gets injected into the plaque. The other medicines are quite a bit of volume. So at the time of the injection, most guys say that generally the Verapamil or Interferon is a little bit more uncomfortable compared to the Xiaflex. But in the first 24, 48 hours, it's kind of the flip where the collagenase typically causes more discomfort compared to the Verapamil and the Interferon. The timing of the injections is also a little bit different. Generally, there isn't a significant delay in terms of going back to sexual activity that you would see with Xiaflex. After each Xiaflex injection, you have to wait 2 weeks before engaging in any sexual activity, compared to Verapamil and Interferon. Usually, I say about 24 hours. As long as you're not having a lot of pain or discomfort, you can go back to sexual activity. Both the Verapamil and Interferon usually will inject them every 2 weeks compared to the Xiaflex, which has kind of a unique protocol.
Got it. No, that makes a lot of sense. So let's say, we're not good candidate for the injectables, or maybe the injectables don't work. Where do we go from there?
Yeah, so most guys that are coming in for evaluation, we always kind of present the surgical options. You kind of can know right off the bat if they're interested in surgery, or there's like no way in hell that they're going to have someone operate on their penis, which is fine. But in folks that have either already undergone previous therapy, so with intralesional injections, or ready to move forward with surgery, typically we talk about do we do one of those ultrasounds to kind of better figure out which surgery is going to be right for you. And kind of the main things that we kind of evaluate is kind of the degree of curvature. How large and how calcified the plaque is, the location of the plaque, and associated erectile dysfunction. In terms of kind of generally with surgical procedures, we kind of think about it as shortening procedures and then kind of lengthening procedures. Shortening procedures generally work on the side opposite of where the penis is most curved. And there's lots of ways to kind of do it, but basically you can either remove a piece of that outer layer of the coverage of the erectile body, or create a little window and place some permanent stitches that basically tension the penis, that when you do have an erection, it prevents that asymmetric expansion as a result of having the plaque. This doesn't do anything with the plaque. The plaque kind of stays where it is, but would essentially fix bothersome curvature.
So you're pulling the penis back the other way, basically, to fight the curvature. Now, you said shortening procedure. Most guys hear shortening of their penis. They're not too enthralled with that.
Exactly.
Please discuss.
Yeah. So, I mean, most guys aren't excited about that, especially if they had, Peyronies for a while, or have kind of comorbid erectile dysfunction where they've already lost quite a bit of length. And that's another thing that kind of factors into the decision. And we kind of evaluate their stretch penile length to kind of get an idea of, how much length are they realistically going to use or lose. And, with that being said, it really depends on how much curvature you're starting out at. Generally with each correction of about 10 to 20 degrees of curvature, you stand to lose about 5 millimeters on the short side. So generally in someone that has less than 60 degrees of curvature, I'll usually counsel them that it's likely that you're going to lose about 1 centimeter to 1.5 centimeters on that longer side to get it so that it matches up with that shorter side. And for a lot of guys that have, kind of average length or greater, that's not necessarily a big deal. But in some guys that are really, concern regarding their penile length, then this procedure may not be kind of the best option. Certainly there are certain techniques that we can utilize to help reduce the shortening, but that certainly is kind of one of the main considerations with this procedure.
That's a big consideration for sure for guys. I think guys are pretty sensitive about that. Are there any other risks? Now, just to be clear, just so that we get all the nomenclature right, this shortening procedure you're referring to is more like a plication procedure. Is that the other term for it, basically?
That is correct.
And so what are when you counsel patients specifically on plication, we'll get to the other ones later, what are the risks should they be aware of aside from shortening? From the procedure?
Yeah, so other risks that we kind of talk about is kind of new or recurrent curvature. It's really hard, at least based on the literature, to kind of describe, what percentage are going to recur or what percentage are going to get, curvature at a different location. I generally describe this procedure as kind of a Band-Aid on the situation because we aren't really addressing the underlying condition, and it's possible that it could pop up somewhere else. But generally, I would say that the chance of kind of a recurrence at that same location is probably about 5 to 10%. Outside of the shortening that we kind of talked about, other things that I also talk about is changes in sensation of the penis. With plication procedure, generally in the guys that do have it, it's temporary, and I would say that pretty much 99.9% of the time with as you move further out from the surgery, everything goes back to normal. But initially, some guys will be like, well, this feels different or feels a little bit numb on one side. And that's usually the result of us just, manipulating the nerves that kind of provide that sensation during the procedure, not necessarily cutting them or injuring them, but they kind of get paralyzed or shocked, and it takes a little bit of time for them to kind of wake up as a result of just, having the surgery down there.
Any effect on erections?
Generally, no. Typically what I quote is about 1% effect on erectile function with the plication procedure, primarily because we're not really affecting the mechanism that leads to the trapping of the blood within the penis. We're doing pretty much all the work from the outside of the erectile body. In comparison to kind of the other surgical procedures where, there certainly is an effect of worsening erectile function.
All right. So for the guys out there thinking, hey, doc, you lost me at shortening, what other options do we have surgically?
Yeah, so in guys that really have more pronounced curvature, and for me, usually that's more than 60 degrees, or if they have a significant hinge effect where it really buckles at a location, those guys are really going to benefit from some sort of incision or excision procedure where we now start to work on the side that has the plaque or has the area of most curvature. And the idea here is basically we want to kind of cut out that area of kind of damaged or scar tissue that's present in that tissue overlying the erectile body. But we need to kind of fill that area in with some sort of material to make it so that when you do have an erection, all the blood doesn't leak out and you're still able to maintain your ability to have, a good, strong erection.
What's usually used for, what kind of material are you using to put there to cover that gap?
Yeah, so there's a lot of different materials that can be utilized. The most common material that I use and that I really like is cadaveric heart tissue. So basically taken from organ donors from their heart. It's been kind of processed, it's been sterilized, free of any viruses or any other kind of infectious diseases. And the main reason that we like it is because it's really strong, it's very robust, and it doesn't contract. So that would be kind of another consideration if we put some other material there that is going to turn into kind of another ball of scar tissue and cause kind of recurrent curvature.
So this sounds like a more involved procedure. I mean, you're literally removing the plaque, you're exposing the erectile bodies, where all the blood goes, you're covering it up with a foreign material. I'm assuming this is more high stakes and more risky. Like, are there additional risks that guys should be aware of with this procedure?
Yeah, so I would say in terms of, technically as well as kind of the recovery afterwards, this procedure is definitely more involved compared to the kind of plication procedures. The main kind of side effect that we would consider in terms of selecting the right patient would be their erectile function. Like I mentioned before, we want to figure out the guys that have pretty good erectile function, because really that's going to be the only guy that I would consider offering the surgery to. And folks that really have poor erectile function, it doesn't really make sense to do this, because you may have the straightest penis, but if it doesn't work anymore, it's kind of pointless. And they may be better served by doing something like a penile implant. For the guys that have good erectile function, that we've kind of confirmed using that ultrasound that we talked about beforehand, and generally I quote them that there's about a 20 to 30% chance that we make your erections worse after this sort of surgery. And for guys that are on pills, that may mean that you're on injections, or if you don't use anything for erectile function, that may mean that you have to start using pills. So that's probably the biggest long-term side effect of this sort of procedure. The other side effects, would be kind of changes in sensation. With this sort of procedure, typically we need to move the nerves out of the way, much more than we would for a plication procedure. And that can lead to changes in sensation, some of which can be more permanent, although pretty rare. And then the idea of recurrent or persistent curvature in guys that really have a pretty significant amount of curvature. So, potentially, 120 degrees of curvature. Generally, we try to cut out as much of the kind of dense scar tissue that we can. But even then, after we kind of do those maneuvers, they still may have a little bit of residual curvature, and they may need, even at the time of the procedure, an additional plication procedure to kind of get them, essentially straight. In the future, it's also likely that you could redevelop scar tissue at that same location, since we did surgery on that area and put this graft tissue. And I would say that chance is probably about 20, 30% that you develop kind of recurrent scarring or contracture in that area as well.
And with these, both with the plication and with this grafting procedure, is the expectation that your penis is going to be completely straight afterwards, or should we come in with a certain, decreased expectation, like it's not going to be perfect, but where can we get it to, kind of thing?
Yeah, exactly. So, preoperatively, generally, I counsel patients that our goal is really to get your erection within 10 degrees of straight. And that's really kind of, our kind of definition, primarily because, some curvature, like we mentioned before, is normal. And, within 10 degrees, most guys are able to have penetrative intercourse and don't have any major issues. It is kind of a decision that needs to be made, when you are asleep. And that's really important that we kind of know and understand from both the patient side as well as kind of the provider side that, what you kind of expect. That's certainly my expectation. We have some patients that may say that, hey, doc, if we're doing like a plication procedure, get me within 30, don't overdo it, that, I lose like more length than I need. And so it's kind of a intraoperative kind of thing to kind of figure out, is this kind of what the patient would like, and what would they expect and be happy with after the surgery, and kind of balancing that with kind of the risks of either further plication or cutting out more of the plaque, or kind of the more nuance of the surgery.
So a little bit of, for both the plication and the grafting, we're going to do a little surgical expectation lightning round. For those two procedures, number one, any kind of preparation that's required of the patient?
Yeah, generally not. The only thing I would say is that in pretty much all the surgery patients, as long as they've completed that ultrasound beforehand, there isn't any special preoperative workup that you would need outside of any sort of anesthesia clearance.
Is both of them require general anesthesia?
Yep.
And are they generally outpatient, or do they have to stay overnight?
All these cases are outpatient. We use kind of a series of different numbing blocks during the procedure, as well as provide some other pre-medications that can help with pain afterwards. And I would say generally, a lot of these patients do very well with pain, enough so that we probably send a majority home without any sort of narcotic pain medications. And we really just do it on a case-by-case basis.
How long do they have to be off their feet, or do they?
We actually recommend that they don't be off their feet. So walking certainly is good, and we don't want them to go home and just be laid up for a week. For the kind of the two procedures, I would say generally the recovery for the plication surgery is a little bit easier, and typically we say it's about, I would say, 4 weeks. For the incision or excision procedure, typically it's a little bit more involved, and the recovery might be a little bit more involved. Generally, I say it will probably be 6 to 8 weeks before you can kind of resume normal sexual activity and kind of get back to kind of other things that they may be doing, exercise and things like that.
What about like driving and going back to work? Is that pretty few couple of days, or is that like usually a week? What do you usually recommend?
Yeah, so for driving generally is okay as long as you're not on any narcotic pain medications and you don't have any severe pain. With the plication procedure, I would say most guys go back to work within a couple of days or a week. With the plaque incision and grafting, I would say 2 weeks to be on the safer side, primarily in terms of a little bit of discomfort afterwards and the degree of bruising and swelling that the patient may have. But most of these guys will go back to work. If they're working like a desk job or they're working from home, then they can kind of navigate around it. It's this, like I mentioned, we don't want them laid up in bed all day. So if they can take have a lighter day or do light duty at work, certainly that is usually okay.
Now, you had mentioned a little bit in terms of recurrence, but generally speaking, for these two procedures, like, okay, if a guy is going to go and commit to surgery, what's the durability? I mean, long term, what are the chances that they may have to get another procedure or deal with this again later in life?
Yeah, so I mean that's really tough because some of these guys that we're seeing are very young, 18, 20, 22, and this is a condition that they're going to be living with the rest of their life. Generally, I'd say that the chances of getting a recurrence or developing kind of new plaque or curvature that's bothersome is probably on the order of 10 to 20% in someone's lifetime. It may be a little bit higher depending on kind of what you look at, or maybe a little bit lower if you look at kind of series of surgical procedures. But generally, that's what I use to kind of counsel guys. But the thought is that both of these treatment options, at the end, when you wake up, you should be pretty much almost straight. And they also would address any sort of other abnormality like like a hinge effect that we would not be able to address with injection therapy, and would certainly also limit your ability to have penetrative intercourse safely.
Now, speaking of that, so again, you had mentioned that these two procedures really are intended for guys with normal erections, or at least functional erections, with or without assistance. What about the guy that comes to you with really bad Peyronies, really bad curvature? And by the way, I can't get an erection on top of it. What do you offer them in that situation?
Yeah, so I mean, those patients are going to be best served with an inflatable penile implant, where basically we're going to kind of kill two birds with one stone. And the idea is that we replace the erectile tissue with an inflatable device that's completely on the inside that provides an erection on demand. By placing the implant itself, it essentially acts as a tissue expander and can kind of push against the plaque. So in guys that have fairly mild curvature, less than 30 degrees, generally just having the implant alone and inflating it, deflating it over a period of time can correct that degree of curvature. In folks that have more curvature or have a very dense or large plaque, typically at the time of the procedure, we can do something like a plaque excision. But now that we're relying on the implant to provide erections, we've kind of negated the chance that we make your erections worse, which is kind of the main side effect of the plaque incision and grafting procedure if we did it just primarily. So in those patients, we're able to kind of best preserve the length of their penis. We can address the curvature or any other associated penile deformity, and then we're giving them pretty much the ability to have very reliable erections.
Now, so that's interesting. I'm sure a lot of guys say, hey, that doesn't sound so bad. What about guys who have, like you said, kind of, I'm not sure, mediocre or just subpar erections? Maybe they're doing injectable therapy. Maybe they're taking a lot of Viagra. Are the implants an option for them as well, or do they not qualify because they're still able to get erections?
No, I would say those patients would also qualify for an implant. And it really depends on, what the patient's kind of expectations are. I think the key thing with the implant is that, once we kind of cross that bridge, obviously we can't go back and you can't start using pills and injections again. But in the right patient, even if they are taking Viagra and still able to get an erection that's somewhat sufficient for penetrative intercourse, or using injection therapy, and have bothersome Peyronie's disease, they likely are still going to be best served with an implant.
Got it. We're not going to get too deep into the weeds with implants. We did a great podcast episode recently about that, so guys can reference that. But what I do want to chat about in the time that we have left is a lot of guys ask questions about more novel or experimental treatments surrounding Peyronies, and I want to go through some of them with you that have come up. One of them is Iontophoresis. What the heck is that?
Yeah, so basically the idea of this is it's essentially iontophoresis or electromotive therapy, and the idea is that we can place a topical medication on the penis where we think the scar tissue is, and then we apply a mild electric current to drive that medication, directly, towards the plaque or into the plaque. It sounds awesome, but it never really has been proven. It was really explored maybe 10, 20 years ago with medications like the Verapamil that we now inject, or dexamethasone, which is a steroid medication, but it never really panned out, primarily because we weren't really able to prove that it was efficacious. Other things that have been looked at and are still kind of being looked at is low intensity shock wave therapy. For a long time, shockwave therapy has been recommended in folks that have penile pain associated with Peyronie's disease. But there's been kind of mixed evidence in terms of the effect on plaque size, changes in curvature, or any other associated abnormalities. So generally, we still consider low intensity shockwave therapy, which is not radiotherapy, still kind of experimental for Peyronie's disease.
And is the idea, the mechanism there, that the shocks actually like soften up the plaque? Is that the hope there?
Yeah, that's kind of the idea. And, shockwave therapy overall has been around for decades, and we use it for, things like kidney stones, which have a significant amount of calcification. And the thought is that if you have a plaque that has, a significant calcification, we could kind of build off that same idea. It doesn't quite work that way, since we're using kind of different energy levels, different applicator. So there's still a lot of research that needs to be done to kind of figure out, is this really going to be a realistic option for guys that have Peyronie's disease and want to improve curvature?
Now, one thing you hear about basically everything from knee pain to erections to you name it is PRP, or that platelet-rich plasma. What are your thoughts on that for Peyronies?
Yeah, I mean, I think along the lines of low-intensity shockwave therapy, there really isn't great evidence for it quite yet. Early on, even a couple of years ago, there have been some animal studies that were done that kind of looked at using PRP injections directly into the plaque, and what they found was that it actually increased the plaque size, because as you can imagine, PRP, there's a lot of growth factors and stuff like that. And in Peyronie's disease, basically, we want to do something that doesn't increase, collagen deposition, and doesn't increase kind of more scarring. So the animal studies kind of suggested that it potentially could make the plaque larger. There's some ongoing studies that are being done with PRP in humans right now and in kind of clinical trials. And generally, there have been kind of some smaller retrospective studies that have suggested that it can potentially improve curvature. But, at this point, I don't think the literature and the research is strong enough to kind of support that for clinical use. And it'll be tough to know, at least without that, basic understanding of, how does it work, whether or not it really comes into kind of prime time over the next, 5-10 years.
Got it. And the last one that comes up in discussion sometimes, although I'm a little mesmerized by it, is radiation therapy for this. Have you heard of this as well?
Yeah, I mean, this is something that largely is probably historical at this point, but the use of external radiation directly to the plaque, has certainly also been explored. I would say that there are risk with undergoing radiation treatments, such as secondary malignancies and other superficial skin changes, and we don't really know the efficacy. So I think, out of the things that we've kind of discussed in terms of kind of more novel experimental things, radiation therapy is certainly, likely out in terms of the next, new therapy.
Got it. So it sounds like these more novel or experimental treatments are just that, and probably not quite ready for prime time by the sound of things. Going back to surgery for one last clinical question, in the discussion we had, it sounds like these procedures are pretty nuanced. They're pretty technical. There's not a great margin for error, and they can potentially really cause some real problems if done incorrectly. If you're a guy out there thinking you have Peyronies, you think, okay, maybe I tried the XIAFLEX, maybe I didn't, maybe I want surgery. What are you looking for in a surgeon? Like, any questions you should be asking, any qualifications you should be looking for? Because again, you're really putting your life in their hands in some ways, and there's a lot at risk here.
Yeah, exactly. I agree. I mean, it's very important to get it right the first time because unfortunately we see a lot of guys that have had, things like a placation procedure or have undergone kind of a series of collagenase injections. And then at the end of the day, they're not happy and are looking for kind of more definitive options. I think when looking for a surgeon, I think it's important to understand that not all urologists kind of deal with these kind of very specific medical conditions. And it's important to kind of search out someone that does. So it's important to kind of ask about, how many patients do you see? How many of these surgeries do you do? And, what other kind of, professional activities they may be involved in. A lot of the kind of high volume folks that do Peyronie's disease, everyone kind of knows each other. And I think it's also important to kind of seek out, second opinions if you really are trying to find, a person or surgeon to really work with. There are professional societies that are available. The Sexual Medicine Society of North America that has a great patient-facing website as well that has profiles for kind of fellowship trained specialists in men's health and Peyronie's disease, which is also a good resource for patients that are looking for a surgeon in their area.
That's great. If you can provide that for me, I can put it in the show notes and we can, that guys can reference that link. That would be great. And is there a magic number in terms of, you said, how many cases do you do a year or stuff? Is there a range that guys should be looking for? 10, 15, 50?
Yeah, I mean, I would say it's tough to have a range, especially with, it depends on the specific procedure. So I would say with, placations are certainly more common. And I would expect that even kind of a high volume place would be doing a lot more of those. The plaque incision or excision and grafting procedures, we don't do them that frequently, primarily because it's about patient selection. I would say any place that's doing more than 5 or 10 a year, I would consider kind of high volume.
Okay.
So it is a very kind of specialized procedure. And then in terms of kind of implants, I mean, the 95th percentile for penile implantation among urologists is 5 implants a year. But it's very commonly that there's, high volume implanters. I'll do 50, 100, 150, 200 implants a year. So, kind of asking these questions certainly can be important. But I think more importantly, to kind of develop a relationship with your surgeon and kind of, understanding that you kind of have similar expectations and you're kind of on the same page, is probably equally as important.
Dr. Patel, thank you so much. This has been extremely helpful. I know the guys will find it helpful. And yeah, if you can provide that reference, that would be amazing. Before we let you go, I'm going to ask you a question I ask all our experts at the end of the show, which is, the idea here at Better Man Clinics is really to help guys achieve their best life possible, both clinically and personally. And you've obviously reached a significant level of success in your life. What's the secret to your success?
Yeah, I would say the secret is probably just be diligent and kind of follow through. If there's something that you're really passionate about, you really need to, give it 110%. And if you do, eventually things will work out and you certainly will have a lot of obstacles. So that'd be my one piece of advice.
That's a good one. That's definitely a good one. Dr. Patel, thank you again for joining us and for all your insights. And for all the guys out there, thank you for watching. And remember our mantra here at Better Man Clinics: your best life is a journey and not a destination. And use every day to get just a little bit better. We'll see you all next time.